did the years go so quickly, my love? How did we get to be gray? Decades go by in the blink of an eye. It still feels like just yesterday. The first time that I heard you say, love me forever and hold me right now. Gather our memories like this. I know we'll never be old anyhow.
Everybody can find their seats.
Anytime we
grab some breakfast because we have a lot of food over there. I'd like to welcome you all. My name is Meg Barron. I'm the Executive Director for the Alzheimer's Association here in San Antonio in South Texas. And I am very pleased to be here in Kerrville for our first in a very long time educational symposium. So thank you for having us and thank you for being here. I first want to thank our committee who helped put this on for us. And if any of our committee members are here, would they please stand up? Thank you. We really couldn't have done it without you guys. Thank you. And I also like to thank our sponsors that have their tables out in the lobby area. So if you have time during the break or you just want to take a walk, please go and visit them. They have a lot of useful information. So thank to our sponsors here today. I especially want to thank the Perry and Ruby Stevens Foundation who made this symposium possible. So thank you very much. And if you are getting CEU credits and have any questions, we have staff, there's Joe right there, but staff from the UT Health Science Center that are providing those credits. They'll be here to answer any of your questions. So again, thank you for having us here today, and I'd like to introduce Maxine Perez, who is our program specialist who was working on this symposium for quite some time. So here is Maxine.
Not very good at speech in public, even though I do good presentations, but here it goes. Thank you for coming this morning. I know that it's pretty bad. We were expecting the bad weather this morning, but now we hear it's not until tomorrow, so that's very good news. Again, just a few things. The folders that you received this morning, they contain information. Some of it is a survey of the program. We want to know how we can best improve it. What things should we change, or what other things should we include in our presentations when we do a summit or a symposium of this nature. Also in your package, you'll see the sign-in form. That is it's going to be on the right side pocket of your folder. And it says the sign-in form is only to capture demographics for our funding purposes when we apply for funding, grants, and other funding resources that are available to nonprofits. We like to include those numbers in there as well. And also in your conference packet, you have the agenda, as well as the CEU information on the left side of your folders. If you have any questions or any concerns regarding the CEUs, please visit with Joe. He'll be by the registration table. Anything that you need, please come see us. We're in front of, outside the hall. You know, Jenny, myself, and the staff of the Alzheimer's Association. And once again, we want to thank you for coming in today. And my next guest, of course, is going to be one of our committee members, Joe Carroll, to introduce our first speaker. Thank you.
Good morning. I have the pleasure of introducing Dr. Anand Menhendale. Most of you here in the community probably know Dr. Menhendale. He's board certified in neurology and addiction medicine. He's currently in private practice with the Phoenix Medical Associates, and he's the Chief Medical Officer at the ranch at Clear Springs, overseeing the quality and care of the residential program. Currently, Dr. Menhendale is on the governing board for the Texas chapter of the American Society of Addiction Medicine. He is a consultant to the Texas Medical Association's Physician Health and Rehabilitation Committee. He's the medical director of the Biomedical Ethics Committee at Peterson. And he has been selected, and this is a real honor, for the last 5 years. He has been one of the super doctors named by Texas Monthly. And less than 5% of physicians in Texas are on that list. He was also named in America's Top Physician list in 2014. He's authored multiple publications and programs for physicians. So Dr. Menhendale, welcome.
Well, thank you, Joe Carroll. My father would be skeptical if he heard that. My mother would say that to about 10 more people. It's an honor to speak here on Alzheimer's disease for Alzheimer's Association. It's one of the most devastating diseases we have, and I live in Kerrville, Texas. So I don't know whether you know this or not, but I believe this. All Texans have this genetic switch that goes off when they're either 150 or 200 years old. And says, okay, let's move to Kerrville and we handle its patients. So these are all my patients. I have tremendous amount of experience with Alzheimer's disease. Practice medicine, in any specialty whatsoever, you're going to have to deal with Alzheimer's disease. Before we start my presentations, I would like to show you a testimony by a comedian named Seth Rogen, who gave before the Congress. So I hope this runs okay.
C-SPAN networks bring you long-form public affairs programming from the nation's capital and are a public service of your television provider. C-SPAN, created by cable.
Now we'll turn to Mr. Seth Rogen. Mr. Rogen, welcome, and please proceed.
Thank you very much for having me, Mr. Chairman, Ranking Member Moran, and the members of the subcommittee. Thank you for the opportunity to testify today and for the opportunity for me to be called an expert at something, because that's cool. I don't know if you know who I am at all. You told me you never saw Knocked Up, Chairman, so it's a little insulting. But
I want the record to note.
Very important, guys.
I want the record to note this is the first time, I will wager this is the first time in any congressional hearing in history that the words knocked up.
Hey, you're not going to like the rest of this then. First, I should answer the question I assume many of you are asking. Yes, I'm aware this has nothing to do with the legalization of marijuana. In fact, if you can believe it, this concerns something that I find even more important. I started dating my wife Lauren 9 years ago when her mother was almost 54 years old. The first time I met her parents, being the mensch that I am, I was excited to spend time with them and make Lauren think I was the type of guy she should continue dating. It was this trip, the first time I met my now mother-in-law, that Lauren first admitted to herself and then to me that something was off with her mother. I guess the clues were unfortunately easy to spot since both of Lauren's mother's parents had Alzheimer's disease. Soon after this trip, at 55 years old, Lauren's mother was diagnosed with early onset Alzheimer's. Now at this point, my impression of Alzheimer's was probably what I assume most people's impression is. I thought it was something only like really, really old people got, and I thought the way the disease primarily showed itself was in the form of forgotten keys, wearing mismatched shoes, and being asked the same question over and over. This period, which was the only way I'd seen Alzheimer's displayed on movies or television, lasted a few years for Lauren's mom. After that, however, is when I saw the real ugly truth of the disease. After forgetting who she and her loved ones were, my mother-in-law, a teacher for 35 years, then forgot how to speak, feed herself, dress herself, and go to the bathroom herself, all by the age of 60. Lauren's father and a team of caregivers dedicate their lives to letting my mother-in-law be as comfortable as she can be. They would love to do more but can't because, as you've heard, unlike any of the other top 10 causes of death in America, there is no way to prevent, cure, or even slow the progression of Alzheimer's disease. Another thing I didn't realize until I was personally affected was the shame and stigma associated with the disease. It was before I was born, but I'm told of a time when cancer had a stigma that people were ashamed by. Celebrities and other public figures that were stricken would hide rather than be voices of hope for people in similar situations. And although it's turning, this is currently where we are largely at with Alzheimer's disease, it seems like. And it's because of this lack of hope and shameful stigma that my wife, some friends, and myself decided to actually try and do something to change the situation. We started Hilarity for Charity. Hilarity for Charity is a fund we have as a part of the Alzheimer's Association to raise money to help families struggling with Alzheimer's and support cutting-edge research. That's right. The situation is so dire that it caused me, a lazy, self-involved, generally self-medicated man-child, to start an entire charity organization. It was through this that we felt we weren't just complaining there was nothing to be done, but actively taking steps to do something. Instead of being disappointed that young people were so misinformed about the reality of the disease, we've started to educate them. We recently started a college program that allows university students to hold their own Hilarity for Charity events, and in the month since it started, 18 schools nationwide have signed up to hold events. The fact that we actually got college students to stop playing video games and volunteer their time is a huge accomplishment, especially considering both Xbox One and PlayStation 4 came out this year. I'm sure these people know what I'm talking about. For a few reasons. One, I'm a huge House of Cards fan. Just marathon the whole thing, had to be here. Two is to say, people need more help. I've personally seen the massive amount of financial strain this disease causes, and if the American people ever decide to reject genitalia-driven comedy, I will no longer be able to afford it. Please don't. Therefore, I can't begin to imagine how people with more limited incomes are dealing with this. As you've also heard, studies show that Alzheimer's and related dementia is the most costly condition in the United States. Yes, it's more costly than heart disease in a country where for $1.29 you can get a taco made out of Doritos. They're delicious, but they're not healthy. While deaths from other major diseases like heart disease, HIV, and strokes continue to decline, deaths from Alzheimer's have increased almost 70% in the last 15 years. Over 5 million Americans have Alzheimer's, and at this rate, in 35 years, as many as 16 million will have the disease. The third reason I'm here simply is to show people that they're not alone. So few people share their personal stories, so few people have something to relate to. I know that if me and my wife saw someone like me talking about this, it would probably make us feel a little less alone. Americans whisper the word Alzheimer's because their government whispers the word Alzheimer's. And although a whisper is better than the silence that the Alzheimer's community has been facing for decades, it's still not enough. It needs to be yelled and screamed to the point that it finally gets the attention and the funding that it deserves and needs. I dream of a day when my charity is no longer necessary and I can go back to being the lazy, self-involved man-child I was meant to be. People look to their government for hope, and I ask that when it comes to Alzheimer's disease, you continue to take more steps to provide some more. I would like to thank the committee again for the opportunity to share my story and to voice my wholehearted support for the continuing work that pursues a cure for Alzheimer's disease. Thank you very much.
Thank you, Mr. Hogan. That was great.
So I think that's a good introduction to Alzheimer's disease. I like Seth, and because one of my sons has moved to New York and he does stand-up comedy in New York, so I like comedians as a rule. First, talk about what does it mean to be dementia? Because people are confused about what dementia is. Even when patients come, is that better? Is that better? Maybe this is better. I don't know. One of these will be better. My problem with mics today is that I'm at an age where I need I have trifocals, but I need quadrifocals or something. This is kind of just out of zone for me, but I'll try to make it work. So the problem is people come to me and say, well, somebody referred to them for Alzheimer's disease. And they'll say, I don't have Alzheimer's, I have dementia. And I try to explain. So it's important for us to first understand what dementia is. There are two major categories of cognitive dysfunction in neurology. First, which is not politically correct to say, it's called mental retardation. It's called developmentally disabled. But I'm an old neurologist for 30 years, I still call it mental retardation. And the other is dementia. Mental retardation means that you never had cognitive function to begin with. I mean, you never had it. Versus dementia means that you had cognitive functioning, thinking, memory, intelligence, up to a point, and you begin to lose it. It's basically a symptom, you're losing cognitive function. It's sort of like fever. it's not a diagnosis by itself. It's a big category that you're losing your cognitive abilities. And underneath dementia, there are varieties of dementing illnesses, one of which is Alzheimer's disease. So it's really, the best way to call it is, it's senile and pre-senile dementia of Alzheimer's variety, rather than just calling Alzheimer's disease. Because people say, oh, my loved one has Alzheimer's disease, they don't have dementia. And so I'm trying to explain it. It really doesn't matter, but it's important because for me, nobody gets, doctors, family practitioners, internists, they refer patients to me for Alzheimer's, but they're really referring me for cognitive dysfunction. I'm trying to figure out whether it's Alzheimer's or not. Because there are a whole lot of other conditions that I have to rule out before I call somebody Alzheimer's. Because, I am very, very careful in putting the label of Alzheimer's disease on patients. And we will talk, my theme of my talk is trying to diagnose this disease correctly. And one of the problems is that, at least in one study, approximately 10% of people in the United States that have been diagnosed as Alzheimer's disease don't have it. That's a lot of people. If 5 million people have Alzheimer's disease, 500,000 people are misdiagnosed who have Alzheimer's disease. So it's really important for us to understand what this disease is. It's not just, grandma, forgetting about keys. My chief used to call it, if you forget where you kept your keys or forgot the name of a friend or somebody you're trying to speak of, that's not Alzheimer's disease. If you have a key in your hand, you don't know what to do with it, that's Alzheimer's disease. It's far more malignant, far more pervasive. However, one of the other problems we have is the fact that we'll talk briefly about pathology of Alzheimer's and what happens in the brain. But one of the problems we have is we suspect that the pathological changes that occur in Alzheimer's disease occur way before people even begin to have problems in their memory or anything like that. And a lot of people have problems in memory as you get older. I call that simple senescence, or I call it simple senility. It's just getting old. I have trouble remembering things, remembering people's names and so on and so forth. So that, you don't want to diagnose something that the patient doesn't have. However, you do want to diagnose Alzheimer's early on, that you can start some of the medications that are available that can slow down the progression of the disease. Seth talked about there is no cure or there's nothing that slows it down. We actually have a medication that slows it down. It's not the greatest thing in the world, but it's a medication nonetheless, and it's a baby steps that we're going to take. So, out of all dementia cases, Alzheimer's probably constitutes about 2/3 of cases, and many of them they run in families. The other big major type of dementia that you see is vascular dementia, not getting enough blood flow to the patient. And generally speaking, the way you differentiate between vascular and Alzheimer's disease is somebody begins to lose their cognitive functioning. In Alzheimer's disease, it'll slowly go down like that. Versus if you have somebody has vascular dementia and getting many strokes in the brain, their cognitive functioning will be like this, and there'll be a stepwise decline because they had an event, a small stroke. They'll plateau out for a period of time, and another stepwise. So talking to patient and getting history is very, very important in this disease and in practically any disease. And I've been practicing neurology for 32 years, and I teach nurses and other doctors about is that, and your doctors, they don't talk to the patient, which I find amazing. They bring their little laptops into the office, never make an eye contact, never talk to the patients. And neurology residents, they don't have to think and talk to the patient, just order MRI scan and that's it. So the whole neurology residency consists of how to fill out requisitions for an MRI scan. However, MRI scan is generally pretty useless in Alzheimer's disease. We'll talk about some of these other things. So there are other things where you'll have cognitive decline. One of the one of the things that is very important and frequently misdiagnosed is depression. When you become old, as we become older, early on, when you're 25, 30 years of age, when you're depressed, you report to people that I'm sad, I'm depressed, and I don't know, I don't want to eat, I'm not enjoying anything that I'm doing. That's the classic signs of clinical depression. However, as you get older, you don't come to my office and report that I am depressed. If you have a depression, say over the age of 65 or so, what you will come to me and report to me that you have memory problems. You have memory problems, which is when a patient walks into my office and they tell me that they have memory problems, I'm really excited. And I'll tell you why. Because when I say I'm really happy you said that, and they look at me funny and they say, he's a mean little guy that just enjoys our disease or what. The reason is because, for example, in Alzheimer's disease, Alzheimer's disease begins to affect the brain from top down. And one of the highest brain function is awareness, right? So your awareness goes first, and then your memory. So the classic Alzheimer's patient would be, is husband and wife, they come in here, and the wife is referred to for cognitive problem, and they'll come to the office, and I'll sit down and ask her, ma'am, I'm Dr. Menhendale, and what brings you here? She said, I don't know why, he brought me here. And the husband would go, oh, can I talk to you outside? She can't remember a damn thing, When I hear that, that's ominous. That is what Alzheimer's will present, not when the patient tells me that they have memory problems themselves, And there's a guy named Norman Geschwin, who was considered grandfather of behavioral neurology. He was at Harvard and died a very unceremonious death, which terrifies me. Geschwin always used to say that people who remember that they forget don't have bad neurological disease. So if you remember that you forget, you don't have neurological disease. Usually it means depression or some other thing which can be easily treated with simple antidepressant medication. I don't want to go into the depressing story of Dr. Geschwin. The second common thing that I see in my office is a patient comes to my office with, quote, Alzheimer's disease diagnosis or whatever, and they'll be on 16, 17, 18 medications. I mean, we have some things to write in our history form. It fills and it goes over. And if you go to a doctor, what will happen to you is that you will have, if you go to some symptom or the other, they'll put you on a medication, and then nobody is willing to take you off of those medications because it is a medical-legal nightmare for a doctor to get somebody off of medication. For example, you're on a blood thinner, right? And I say, well, I don't think you need Plavix, I don't think you need Coumadin, I don't think you need whatever. And I stop it. And 4 weeks later, you have a big stroke or a heart attack and you die. So doctor, or somebody who's undilated, for example, epilepsy, right? And they'll come to my office and I say, what happened? Well, I had this event, some whatever, and I went to the hospital, they put me on Dilantin 25 years ago, I've been taking it for 25 years. What has happened in between that? No, I haven't had any problems. But again, I'm terrified of taking those people off of Dilantin because I stopped their Dilantin, 3 weeks later they have a seizure and die. I'm going to get sued, right? So when you take, and that is one of the problems. So when you go to a doctor and they want to put you on a medication, ask questions. It's kind of like Iraq war, you need to have an exit strategy. After 65, get put on a medication. Is there a chance of me getting off of medications? Under what circumstances am I able to get off of it? Or is this for a lifetime? Ask those questions just because doctor, a lot of times, we give you, I hate to say this publicly, but we've got 20 minutes, 25 minutes, and we have serving 25 different masters, Medicare, PQRS, and other alphabet soup, and all that kind of stuff, out of which we have maybe 5 minutes to listen to you and develop a plan, and out of which some of my patients, they can't stop talking. I like to talk, so I understand that, but they can't stop talking, so I can't figure out what the hell is going on. So I've got like 30 seconds to talk to you, and then I would say, okay, I'm just going to give medicine, just take Dilantin and get out of my office. You know what I mean? And that's kind of sad, but that's the way it happens. And you just get on, put on medications. And a lot of these people on 16 medications, they can't think, they have memory problem. They don't have Alzheimer's disease. They just over-medicated and simply start tapering them off of medications, and you're better. Chronic central nervous infection, you don't need to worry about that. That's an odd thing. So we have to do spinal taps on certain people with dementia. It's not an issue in Texas. And I put this on the slide because I trained in Arizona. And we had this whole band called San Joaquin Valley fever. And that was coccidioidomycosis. So a lot of people had cocci meningitis. And they had hydrocephalus, they got demented, and came, and so we had to do a spinal tap. Spinal tap was a requirement in Arizona for workup of dementia. It's not in Texas because it's rare, fortunately. Thyroid diseases, low thyroid or too much thyroid hormone can cause cognitive problems, and usually people have, if they have high thyroid, too much thyroid, they have bug eyes and they're skinny and they're irritable and they're just going all over the place. One of the problems with memory though, and I don't know whether Dr. Goldman, my friend, is going to talk about what memory is neuropsychologically. But when people say, I have memory problems, for example, people with hyperthyroidism or people with attention deficit disorder will come in and they'll say, I can't remember. So when you talk to them, you just tease that particular symptom out just a little bit. And it's important. That's why histories are important. So what do you mean you can't remember? So you force them to remember something. I give them 3 things, black telephone, yellow flower, and 25 Park Avenue. Remember that. And they'll say, okay. I said, okay, let's repeat it again. Black telephone, yellow flower, 25. I mean, what I'm saying is over and over, they repeat it back to me, and then 5 minutes later I ask them what I said, what I asked. What I'm trying to do is to eliminate attention problem as a cause of memory deficit. If your attention is wandering, you're from one place to another. My attention is wandering because I think I lost my phone somewhere. We'll find out later on. That's what happened. But anyway, this happens to me all the time. So I have Alzheimer's maybe, but I remember I have memory problems, so I figured it out. Losing my focus. And so people have attentional problems, and so therefore they can't remember things. They report to you that I remember things, but they are forced to remember things. The memory is, are you able to lay down new information in your brain and chemically encode it? And memory, when you put it in your brain, if you have a good night's sleep, it becomes nice and solidified and then able to recall it. That's the whole process of laying down memory and recall of the memory. There are a lot more complicated things about memory. But if your attention is wandering from place to place, thing to thing, and all over, I have a little pug, his name is Schreiner. He's a classic case of attention deficit disorder. And I probably have it too, but I'm not going to start diagnosing myself here. But, he's eating something and he's out playing, and a little stick falls in his periphery, and he changes his attention from whatever he's doing to the next sensation that's coming into his mind. And you just look at the stick as one of the most important thing in life. And every single new stimulus that comes in your mind, you would pay attention to that. Because there's part of the brain that is called prefrontal cortex, the front of the brain. And in the front of the brain, that determines the value of a sensation. For example, I'm sitting here and I just saw her picking the pen, the red pen, and write something on the tablet. And all these sensations are coming in. But my prefrontal cortex says that says I don't need to pay attention, valence, or importance to that sensation, right? So I'm going to suppress that and focus on what I'm talking about. And that's what people do. But if you have prefrontal problems or attention deficit disorder, depression, other psychiatric problems, what will happen is your attention will wander from place to place. You'll just give improper valence or importance to what is coming into your field. And you'll forget, you won't be able to lay down a good, crisp encoded memory of what you were doing. So what you were doing, so when I went from one group to another, and when I'm there, I didn't remember why I got there, and I have Alzheimer's disease. People will say that to me a lot. You know, first, if a patient asks me if they have Alzheimer's disease, the answer is almost always no. People who have Alzheimer's disease don't have the ability to ask the question whether they have Alzheimer's disease. So if you're worrying about your memory problem, you don't have it. You need to, yeah, that's important. Some of you, let's not go too far. Cross section of the population, maybe about 4 or 5 of you have it. Or really. That's kind of depressing, but that's the way it is. There are certain vitamin deficiencies that will cause memory difficulties and may look like dementia. One classic one is vitamin B1 deficiency with alcoholism. And that's why people who drink a lot of alcohol, they chew up their B vitamin, and when they come into the treatment or the hospital and we try to detox them and we don't give them vitamin B1 thiamine, what ends up happening, they have hemorrhages in particular parts of the brain where the memories are stored, and they'll develop a syndrome called Korsakoff psychosis. It's a pure memory deficit thing. These people will not be able to lay down any new memories. What am I doing? Why am I doing here? Where am I? What day is it? What am I doing here? They'll keep asking the same question. They absolutely cannot lay down any new memories. And the past memory, there are 2 types of memory. Like going forward is called anterograde memory, which means are you able to lay down new information? They can. And retrograde means all your life from your childhood to now. And people say, you know, well, I don't remember my childhood, I must have been abused. Somebody must have abused me. That's silly, you know what I mean? That's crazy. I asked my chief neurologist, I said, isn't it amazing that people remember things? He said, no, Menhendale, what's amazing is people forget. It's very important, because if you don't forget things, you'd be a neurotic basket case at the age of 3. It's important. Things that are painful, you don't need to hang on to them. Right, like Dr. Golden, the psychologist, trying to dig it out of that sometimes. Right? Right, Dr. Golden?
I knew you would get in something.
So in Korsakoff's though, they cannot anterograde, going forward, they cannot lay down new memories, and there are holes in their back memory. So they'll, and what they'll do, and I don't know whether it's peculiar, it's called confabulation, it's because they're alcoholics or not. But when you ask them, have you met me before? And they'll look at you, yeah, sure, I met you a couple nights ago. We were at Happy's Corner Pub on G Street. I guess it's not there anymore, but it used to be there 30 years ago. And we had a couple of years, and they'll just fill that little hole where the memory is wiped out in his brain or her brain, and fill it with some stuff that's just cool and appears to be cool. That's confabulation. That's what happens with vitamin deficiencies. And generally speaking, you don't need to take large quantities of vitamins, or people take like 27 vitamins and stuff. I think most, as you get older, you should probably take vitamin B12, 1,000 micrograms, and a B complex tablet of some sort. That probably is a reasonable thing. At Walmart, that'll probably cost you $3 for 100 pills. You know? Don't buy it at GNC, the rose petal flavored vitamin B. $3 a pill. Okay, CNS angiitis, I'm not going to talk about it because most doctors don't know about it, and so it's not necessary. Normal pressure hydrocephalus, important diagnosis. Normal pressure, in your brain, you have cavities, right? That's normal. But normally, the fluid is manufactured in your brain, and it circulates through the brain, and it's absorbed from the convexity, from the top of your brain. For whatever reason, the flow of fluid is obstructed, and you cannot lay down, and you cannot absorb the fluid back. So the fluid builds up, and the ventricles get big. And when that happens, the cortex, where thinking and higher functioning is occurring, gets pressed against the inner table of the skull, and you begin to have memory deficit. But in addition to that, you have 2 other things in normal pressure hydrocephalus, which is new onset of urinary incontinence and difficulty with walking. And the walking difficulty is called apraxia of gait. Apraxia is this. as if the blueprint of your walking is gone. It's your muscles are strong, nerves are strong, everything is strong, but the information from the frontal lobe of the brain is not coming down fast enough to your legs, and the blueprint is gone. You're just frozen from time to time. So you have apraxia of gait, you have urinary incontinence, new onset of urinary incontinence, and memory difficulties. And the urinary incontinence is a peculiar one, not the overflow that a lot of older people, women who have had childbirth have. This incontinence is urgency, and what that is because right around those cavities where they're enlarged and there's fluid in it, there are pathways from your brain that go down to the bladder. And these pathways are called social fibers to the bladder. So when you're born, those fibers are not myelinated and not well developed, right? So as a baby, your bladder fills up, it stretches, the stretch reflex is activated, it goes to your spinal cord, and the bladder contracts. This is called an infantile bladder. As you become 18 months, 2 years of age, what ends up happening is that those fibers around the brain that are going to go around the ventricles get myelinated, well developed, and you develop those fibers inhibit that reflex. So if you're in a social situation like this, like I am, if my bladder fills up, if I did not have those fibers, I would just pee in my pants because I would say, I gotta go, I gotta go. And that's called urgency. That's the type of urinary incontinence that people have with normal pressure hydrocephalus. They can present like Alzheimer's disease, but they have these two additional symptoms. And the reason it's important is because that is treatable. You put shunt in their brain, and their memory begins to improve, their gait improves, and their bladder problems occur. And I'm spending a lot of time, it seems like I'm not spending enough time on Alzheimer's disease, but I want to make sure when the diagnosis is made, it's made correctly. I don't want people with 17 medications called as Alzheimer's disease and all families of uproar. I see that not infrequently that people are missing this diagnosis.
Can you make the operation?
Pardon me? For normal pressure hydrocephalus? Yes.
Operate on them?
Yes.
Put a shunt in?
Yes. There are other types of dementias that are, for example, there's a dementia called frontotemporal dementia or Pick's disease, and it's a dementia that's not, it's similar to Alzheimer's, but not really. There are certain differences, and only the temporal lobes of the brain and the frontal lobes of the brain begins to deteriorate, not other parts of the brain. And this, frontotemporal dementia, or it's also called primary progressive aphasia, it's also called Pick's disease. This is a nasty disease. I mean, you are better off having an Alzheimer's disease rather than Pick's disease, because as those frontal and temporal lobes degenerate, as that type of dementia progresses, frontotemporal or Pick's or PPA, your personality completely disorganizes. You begin to do sexually inappropriate things. If they're in a nursing home, they'll defecate and take stools and throw it against the wall. I mean, it is a nasty, nasty behavioral problem. Not to have. For example, I had a patient who had Pick's disease. This is 10 years ago, and she's a lovely, very, God-fearing, religious 70-year-old woman. Unfortunately, had got the Pick's disease. And she came to my office. She had 2 daughters, and they were attorneys, and one was in Austin, the other was in New York. So all 3 of them came to my office, and those daughter attorneys were dressed in Armani clothes, and I mean it was, and so it was very proper setting, and they were all standing there with their briefcases, whatever the attorneys do. But I'm not too fond of attorneys. I'm a doctor. So they're standing there, and their mom sitting on the exam table, right? And I was looking at her, talking to her. She jumps from the exam table, puts her legs around me, and she says, "Mount me, cowboy." And I told her I'm an Indian, but This is what Pick's disease and frontotemporal dementias do. Huntington disease is where you have a lot of movement disorders. It's rare, it's genetically, it's autosomal dominant disease. Prion diseases, maybe I'll just briefly mention them. These are infectious etiology dementia. These are rare. Well, we actually, Dr. Owen and I saw one, and it was confirmed at Cleveland Clinic. By the way, there is no way to fully, completely diagnose, 100% diagnose Alzheimer's disease without the brain biopsy. The absolute, if you have to absolute diagnosis of the disease, you have to do the brain biopsy. However, many of my patients don't consent to that. The other even more ominous medical procedure is an autopsy. They don't consent to that either. But you know, I was a chief resident. This is an interesting story about autopsies. And so as chief resident, and all training programs have to have an autopsy rate, right? 10% of patients who die in the hospital, you know, we are supposed to talk to the patient, the residents, and get an autopsy so we can learn their disease right from the living till the end. And so I was chief resident. I guess our autopsy rate began to drop in our hospital to like 12% or 13%. And my chief, brilliant neurologist, he's 92 years of age today, this year, and still has 1 day a week clinic. Brilliant guy, but kind of absent-minded. So our autopsy rate began to drop. So he called me, he used to call me boy. He said, boy? I said, yes, sir. And he says, well, this is not good. Our autopsy rate is dying. We need to do more autopsies of people who die in the neurology service. I said, well, I'll talk to the residents about it. He said, well, let's do this. He said, I created this form. He said, when we admit patients to the hospital on the neurology, let's just have them sign a consent for an autopsy. That would have done it. However, when I told him, I said, Dr. Sibley, I don't think that's not going to inspire confidence in our patients. When you're admitting somebody for a stroke and having them sign a consent for autopsy, that's usually terrifying to me. So, prion disease are infectious diseases. These prions are not viruses, they're not bacteria. First we started knowing about prion disease dementias was in the island of New Guinea. The women and children were getting dementias, early onset dementias, and we didn't know what they were. People were investigating, they thought it was genetic because women and children were getting it. Eventually we learned that in Papua New Guinea, that tribe that was getting this type of prion dementia, it was called Kuru, K-U-R-U. They were cannibals, and so they were, when somebody would die, a child would die, or a woman, somebody would die, the brain was, human brain was considered a delicacy, and they would feed it to their children and their women, and that's why they got the disease. And one of the missionaries who went to Papua New Guinea came back to New York City, fell down, and had a subdural hematoma. He got it admitted to, I think it was at Langone, if I'm not mistaken, one of the New York hospitals, and got operated on for the removal of the subdural hematoma. The missionary who had gone to Papua New Guinea. And in the op report, the surgeon wrote that he had a nick in his glove, so he got in contact with the missionary's blood during the surgery. 6 months later, the missionary got this prion disease dementia. That's when you have myoclonic jerks and begin to lose your mind. And a year later, the surgeon died from this dementia. And these are Jakob Creutzfeldt disease, mad cow disease, Kuru, and all of those diseases that are prion diseases. Let's talk briefly about dementia with Lewy bodies. This is not diagnosed as commonly as it occurs. And dementia with Lewy bodies behaves very similar to Alzheimer's disease, because you're going to get lots and lots of information about Alzheimer's and stages and with Dr. Goldman and all that kind of stuff. So I'm basically, my job is to tell you what is not Alzheimer's. And we'll get to the Alzheimer's in a minute. But let me see what time I'm supposed to get off here? 9:20. So I have 30 more minutes, right? Good. Because I lost my phone, that's what I was looking for. So anyway. So dementia with Lewy bodies. Dementia with Lewy body is when behaves like Alzheimer's disease with memory problems, thinking problems, remembering complex cognitive tasks. However, one of the early presenting symptoms of Lewy body dementia is visual hallucinations. Visual hallucinations predominate in Lewy body dementia early on. And another important thing for doctors and nurses to remember, if you have somebody with Lewy body dementia, if you give them antipsychotic medications, like if they're agitated, they're hallucinating, right? The standard response of an internist is give them Haldol, give them Geodon, give them Risperdal, any of these antipsychotic medications. They get incredibly worse on antipsychotic medication. You can use very, very low dose of certain types of antipsychotic, and that's a hallmark of Lewy body dementia. There are other rare conditions, I don't know what they are, so. No, I don't want to go into them. Okay. So Alzheimer's was described in 1906 by, you have this slide, right, Mark?
Yeah, you stole this one from me, I think.
No. You have this slide. You know, Alzheimer's, this is Alzheimer's, Augustin Dieter was Alzheimer's first patient. After doing 2 stains, that 1906, he made the diagnosis, and that's why the name, and you can talk more about it. So, for 30 minutes we talked about what it is not. And so, it's a disease, it's irreversible. Once it starts, it's not reversible. There's nothing that we know that can reverse it. It's progressive, and it slowly destroys your memory and your thinking skills. The one thing to remember that Alzheimer's disease is a disease. It's not simple act of senility, as your normal senescence or getting older. It's a fatal, nasty, progressive disease where it completely destroys who you are and as a human being. So it's not just a matter of grandma is just having little memory problems and she'll be all right. This is a devastating disease as it progresses. The most common cause of dementia among people 65 or older, there are about 5 million now, 5 million people who have Alzheimer's disease. And every 5-year age group beyond 65, the percentage of people with Alzheimer's doubles. We'll talk about it. By 2050, we estimate that 13.2 million Americans who have Alzheimer's disease, if current numbers hold true and we don't have a big Armageddon in the Middle East, that we won't have many people with Alzheimer's because we won't have many people if a nuclear exchange occurs there. Most people who have Alzheimer's disease are cared for at home, in assisted living facilities, and nursing homes. The cost of caring for Alzheimer's disease in the statistics that I look for, it's $100 billion a year. Although when I was walking up, they had little, signs and, go here if you have Alzheimer's or something like that down. No, go here if you want to listen to Alzheimer's, whatever. Anyway, on one of the signs I saw the cost was $185 billion or something, it's 175 or something much more than what I'm saying, but I don't know how you figure these things out. So the method would be important to know how you figure out. People say all sorts of statistics, like drug addicts cost society, half, $1 trillion, whatever. Probably true though. So this is important. The risk to first-degree relatives. Okay, this is the rough rule of thumb. So the risk to first-degree relatives of the affected individual is increased 3 to 4 times relative to control. So if you have first-degree relative, brother, sister, father, mother, have Alzheimer's disease, and if let's say you're 65 years of age, your chances of getting Alzheimer's is 3 to 4 times more than your age-matched controls. So the prevalence of dementia, this is not Alzheimer's. Between 65 to 69 is 1.5% of the population has it, 70 to 74, 3.5, and between 95 to 99%, 45% have it. I see a lot of people over the age of 90 years now. It's amazing what medicine has done, and these are intact. I got one guy who comes to my office Sure he's not here. Now he's not here trying to find young women, well, I mean, 70-year-olds, you know, to pick up. He comes to my office and he gets testosterone injection and a prescription for a Viagra, and that's all he's on. So I have nurses who will vouch for that. And usually that injection is given to him by a male person in the office for obvious reasons. So yeah, so there are a lot of people who live beyond the age of 95 and with very high percentage. Clinically, it's a slowly progressive course of loss of cognitive functions, memory, communication skill, judgment, and reasoning. And there is significant impairment in social and occupational functioning, and as the disease progresses, you begin to have behavioral problems like wandering. But these behavioral problems in Alzheimer's disease are nothing compared to what you see with dementia with Lewy body. So, however, as the behavioral problems continue, wandering at night especially becomes a problem, and a locked unit becomes almost necessary for people with Alzheimer's. The early stage of Alzheimer's is considered mild, which lasts for a period of about 2 to 4 years. There is memory loss. They can't remember conversation or events. They ask the same questions over and over. Writing, they can still write, but the writing becomes difficult. They become depressed and apathetic. And this is where the problem occurs. And we'll talk about some newer tests that we have developed to distinguish. Because a lot of times when people come in, I don't see people with just pure Alzheimer's disease. They have Alzheimer's disease with depression. They have Alzheimer's disease with anxiety or whatever. And so it's very difficult to sort out, which came first, or whether depression was a secondary disease, or it's a primary disease in itself, or it's actually all depression, not Alzheimer's at all. And so it's kind of difficult, and it's important to remember that. Now, personality, this slide says that drastic personality changes occur, but they are bad, but they're not as bad as Lewy body. In the first stage or early stages of dementia, they need reminders for daily activities. They have difficulty with driving. Let me talk briefly about driving. Just because you have the diagnosis, I don't think, probably looking around, about 10% of you in this room shouldn't be driving, like that's the same. But just because you have a diagnosis of dementia or Alzheimer's doesn't mean that you can't drive. Just the same way, I'm on the medical board for physician health. So just because the doctor has a diagnosis of depression doesn't mean that he is impaired to practice medicine. You see what I'm saying? Any disease in its early form, however bad it is, you can have all your functional abilities intact. And there has been a significant change in Texas driving law last year as a result of one of the neurologists from Texas Neurological Society, Sarah Austin, was responsible for that. And nowadays, because this is very, very difficult for me to tell somebody they can't drive a motor vehicle. I was involved in a case in 1979. This is a different disease. It's about epilepsy, because epilepsy at that time in 1979 was not a reportable disease. That means if you came to my office and you're having seizures, you had seizures yesterday, it was protected by physician-patient confidentiality, and I could not report you to the DMV or Department of Public Safety that you can't drive a motor. You had to report to the DMV yourself. In '78, I was a young neurologist, first, second year, and so this guy came in. He had epilepsy, on Dilantin, wasn't taking his Dilantin, had seizure the week before, and so I examined everything. And so my chief came in and he told him, you cannot drive a motor vehicle, go to high places, or swim alone. They know what you can do if you have epilepsy. And so he said, and make sure you write that down in your chart, he told me. And I said, okay. And then after the patient said, aren't we going to call the DMV and tell them that take his license away? He said, no, it's not a reportable disease. 3 weeks later, that same guy, there's a husband, wife, and 2 little children on Miracle Mile in Tucson, Arizona. He had a seizure, jumped the curb, killed all 4 of them. Epilepsy is now a reportable disease in all 50 states. But the same thing is occurring with Alzheimer's disease. And I used to punt, because I don't like to be the bearer of the bad news, right? I'm always not a nice guy. And I got Dr. Goldman in my office, so I said, hey, Mark, why don't you do a neuropsychological assessment and tell them whether they can drive a car or not? And I said, Dr. Goldman says you can't, But if he said you can't, then I would say, oh, sure, I say you can drive a car. Anyway, but Goldman would fudge too. He had malpractice too. So you say, but something happens, you can't tell, and all this kind of crap. But anyway. But now with the new driver's law, what you can do is just tell my patients, go to DPS, take a written test, and take a driving test. If you pass it, you can drive it. If you fail it, you can't. Peterson, you had a simulated driving test in the occupational therapy department, but this is much better to tell the patients that they can't drive, is to have the DPS tell them they can't drive. And the other thing is, a lot of times when these people patients come in, there are families that are not the stellar examples of behavior, and there are people fighting to get control of the money and all that kind of stuff. They're trying to portray them as much worse than they are, and it becomes a real battle. The second stage of Alzheimer's disease is considered a moderate stage, and duration is 2 to 10 years. There's no way to deny that they have it. Their memory loss affects all areas of their functioning. They have rambling speech, unusual reasoning, confusion. They get lost in familiar surroundings. They have sleep disturbances. And 80% of the time, they will develop emotional and behavioral problems that are aggravated by stress and change. And little comment here, that if people are agitated, there are a lot, we'll talk about medications if we have time, because I always run out of time. But the problem in older people over 65 is if you give them drugs like Haldol, Seroquel, or Risperdal, or antipsychotic medication to control their behavior, it increases the risk of death from cardiovascular event. So you have to be very, very careful in giving antipsychotic medication. So you layer them with some other medications like valproate or Depakote or an antidepressant before going to the bigger guns like antipsychotic medications. For the difficulty they become rigid, and they begin, as Alzheimer's disease progresses, they begin to become like an infant, basically. All the reflexes that the little baby had will emerge. One of the reflexes is called a rooting reflex. So you tickle the side of their mouth, baby's mouth, and they'll turn their head because they want to drink from the nipple. And so as Alzheimer's disease progresses, they'll begin to have rooting reflex. Babies have what is called a snout reflex like this, and other palmar-mandibular reflexes. Scratch their palm and their chin moves up. That's called a palmar-mandibular reflex. And so all these primitive reflexes will begin to occur. And I have a story about the primitive reflex. My chief wasn't a very nice guy, so we had a medical student and 2 medical students. So they said, where's one of our medical students? I said, Dr. Sibley, which one? He said, the dumb one, the one with the snout reflex. I learned neurology in those settings because you couldn't afford not to. You're publicly humiliated. Fortunately, my daughter is going to start neurology at Columbia, but in New York, and she said, Dad, you'll get thrown out of our program if you talk to the people. It's not politically correct and all love and hug and everything. I hope they learned something. I learned a lot though because of it. So moderately severe stage is just much worsening. Delusions and paranoia becomes, and delusions in Alzheimer's disease can become quite crystalline. There are people up in the ceiling and they wake me up at night. These are not hallucinations. Actually seeing people, it's a sensation that's not there. So if I saw a little pink elephant running around here, that's a visual hallucination. But if I believe that there's a pink elephant running around out there, that's a delusion, because it's a false belief. So, but when Alzheimer's disease people develop delusional disorder like that, false belief, it's very, very difficult to treat. We can give all sorts of antipsychotic medication, and it's very hard to treat. And the last stage of Alzheimer's disease is 1 to 3 years. They are completely confused. They cannot take care of themselves. They fall. They're immobile. They cannot swallow. They're incontinent. Their mood, behavioral problems are extreme. They're delirious. They hallucinate. And I want to make a little point here, is that, and I think Chrisanne, she's on the thing about the end of life thing. We as a group do an incredible job of getting people to hospice and not over-treating people. If they have cancer, we do a great job of it. Unfortunately, with Alzheimer's disease, we don't. And if they're in the severe stage of Alzheimer's, and you're correct about it, there are a lot of caveats. The diagnosis has to be correct and all that kind of stuff. If that is the case, I think that the discussion should occur with the family. The discussion should occur with your doctor if you're young about your end-of-life decisions anyway. And instead of having that person suffer for 1 to 3 years in a nursing home and after losing a little essence of what they have lost, I'm sure if you took a vote here, how many of you would want to live in that particular state? All of you would say no. And so I don't think it's fair, and I think we are not good enough yet in getting 4th last stage of Alzheimer's disease referred to hospice, where families are comfortable, the patients have dignity, and they pass on the way our Creator meant them to, rather than, yes ma'am?
Oh, I was just going to say, hospice versus palliative care?
Hospice and eventually palliative care. I think the transition should start with hospice first. I think. Huh?
Palliative usually comes first before hospice?
Well, depending on, when I think of palliative care, I think of intensive care, palliative care, but whatever, end of life care, whatever, call it whatever you want. We can call it Ray, we can call it Charles. Anyway, so palliative first, then hospital. But what I'm saying is to get them to people who do end of life care, and they start having that discussion and not get them, the important thing is not to get them admitted to the hospital, treat them for pneumonia, treat them for renal insufficiency, IV antibiotics, intensive care unit, and so on and so on. I think that is not a dignified way of taking care of patients. Okay, diagnosis of Alzheimer's disease. This is important, and I'm going to spend a little bit of time about this. I've got 12 minutes. So the way you diagnose Alzheimer's disease is that you go to a doctor's office and a doctor sees you, probably your primary care physician. Either you or your loved one is worried about that you are not right, your thinking is not right, your memory, whatever. So then the primary care physician does whatever and they get referred to neurologist care. So what we do is we get the history, as I talked about, how the disease progressed, whether it's a gradual slow decline, there's a big drop off in the plateau of the disease, or so the history is important. Whether there's family history of Alzheimer's disease, is there any other illnesses that would predispose you to that hydrocephalus that we talked. Our history is very important. So get clinical history, and then you examine the patient. A dying art in medicine. You actually touch your patients. If you're a doctor. I don't know. This doesn't happen a lot these days. We just order tests, right? So then you examine the patient and you look for it. If you think somebody's depressed, right? If you think it's a pseudo-dementia, it's not a real dementia, it's depression and pseudo-dementia, you start seeing grasp reflex and a snout reflex and a palmamental reflex, all the infantile reflex, it's unlikely that this is going to be a depression-causing infantile reflex. It's more likely to be Alzheimer's. So it's very important to actually talk to the patient, examine the patient, and it'll narrow it down. And usually what ends up happening to me is that it gets narrowed down. I'm going to talk about common things occur commonly. And so I tell students that when you hear hoofbeats in Texas, you think of horses and not zebras. So somebody has memory problem in Kerrville, they come to my office, I think Alzheimer's disease or vascular dementia or pseudo-dementia, not Jakob-Creutzfeldt disease or Kuru or prion disease. You know, so three common things that occur. Is this pseudo-dementia? It's depression presenting itself as dementia. Is it Alzheimer's disease dementia, or is it vascular dementia? Those are the three. Don't you think that those are the most common things that I ask you to separate? And so what do you do? At that particular point, you can do the test. And while you're ordering the test, when I order an imaging study for a dementia patient, like an MRI scan of the brain, the reason I'm ordering is I'm ordering it to see if they have atrophy, their brain volume is lost. If they have little areas of dead brain that you see in strokes, that makes it vascular dementia. If they have small tumors that have completely gone unnoticed, occasionally you'll see that. Or so every once in a while, I order an MRI scan and it comes back that they have hydrocephalus, that I completely missed on clinical examination, history and examination. Although I have high index of suspicion, I have missed hydrocephalus. You know, so that's why imaging studies are important. At least, so if you have a diagnosis of dementia, you deserve one good imaging study in your life. You don't need to have MRIs and EEG, MRIs and CAT scan done every year, but you need one MRI scan done to make sure that there's nothing that's going on. I send the patients to Dr. Goldman. He's a neuropsychologist. So he does a battery of tests, lasts for 5-6 hours, a long time. And there are all sorts of puzzles and memory questions. And he actually divides your cognitive, intellectual ability in different domains, you know, like visual memory and all sorts of, like 30, 35 different domains, and test you how you are with respect to your age-match controls. And from that, he writes a long 8-page report, which I never read, but because he's a psychologist and they have the habit of writing too much, But what I love about Dr. Goldman's report is he's got a 2-page graph which all these cognitive domains and the percentage of drop. And just by looking at the graph, it's apparent that this is vascular dementia versus Alzheimer's dementia versus pseudo-dementia and so on and so forth. However, lately though, Dr. Goldman, I don't know where he must have gone to a conference or something. Other than DSM-5 came, the Diagnostic and Statistical Manual number 5 came out. So now he calls it major neurocognitive disorder and not inconsistent with the diagnosis of Alzheimer's. What the hell does that mean, Goldman? Not inconsistent with the diagnosis of Alzheimer's? He doesn't commit anymore. And he's a man, I mean, that's So anyway, so when Goldman equivocates and MRI is, and I don't know what's going on. I also do a test called EEG. If you go to conferences, they don't say that do EEG. The reason I do EEG is a very cheap test compared to the other tests that I'm going to talk to you about. And given all the things, if all they're not metabolically okay, same medicine. So if you do a brainwave test, and in a second, the normal alpha activity is 8 to 13 times a second, right? And let's say I've done the EEG now, and your activity is 11 cycles per second. 8 months later, I repeat the EEG, it's now 7 cycles per second. It has slowed down considerably. Something is happening in the hardware of your brain. That is not an elegant way to diagnose, but it's a good way to diagnose. If I suspect somebody has pseudo-dementia and their background activity is 5 Hertz on the EEG, Kevin is here, he does my EEGs. I mean, you know that there is a hardware failure, so there's something more than depression is going on. However, let me go through. Now the problem is to distinguish between. Let me just go to the table because I don't have enough time. So, okay. Now, in 2015, on the left-hand side, you'll see AD, that stands for Alzheimer's disease. FTD is frontotemporal dementia, or Pick's disease. LBD is Lewy body dementia. PD is Parkinson's disease. And MDD is major depressive disorder, depression. Okay? And on the top part of that thing, you have MRI, which is MRI scan that we talked about. NPT is neuropsychological testing. And then there are 3 different scans that are there. It's called FDG PET, DAT-SPECT, and 4-beta PET scan. So these are different PET scans. 5 minutes, yeah, it's trying to, it'll be okay. I don't have my phone, so I can talk forever. I'm supposed to put an alarm on my phone. Anyway. So when you have diagnostic difficulties, you order these tests, these new scans, and they're expensive. They cost, how much do they cost, Lisa?
That last one, I think she said, was $5,000.
And which one, there are 2 scans that Medicare has begun paying for.
The FDG and the DAT.
But the floor beta is not the last one they're not paying.
Right.
But these first two scans are being paid for. They are important because if you have in Alzheimer's disease, when you see that negative sign on the DAT-SPECT, that means the scan is negative, it's normal in Alzheimer's disease. So if you suspect somebody has Alzheimer's disease, you send in for DAT-SPECT, it completely comes up normal, you're in trouble, they don't have Alzheimer's disease. So if you suspect that somebody has Lewy body dementia, and if they have Lewy body dementia, that their FDG PET will show that there's a frontoparietal problem, DAT-SPECT is positive, and floor beta is positive. But if they have Alzheimer's disease, the floor PET scan is positive, but DAT is negative. It's like moving puzzle, pieces of puzzle. So you order all these 3 scans, neuropsychological testing, and with that you're very, very close to becoming the diagnosis without having to do the brain biopsy and autopsy, the most unpalatable situation. So for the most part, however, if you come to my office, between Dr. Goldman, MRI, neuropsych testing, EEG, we are fairly comfortable. And if I'm not sure, I will tell you, I don't know. I have no problem telling my patient I have no idea what you have. You know, 3 hardest word for a doctor and nurse is I don't know. They'll just come up with just garbage explanations, something semi-intelligent, and just make people believe whatever we do. But I just say I don't know, and you say, and time, just follow them along for a period of time, and it'll show itself. Okay, I think I'm almost done, so I'm going to stop here. Except just quickly show. You have all these amyloid and all that stuff, right? You didn't take it out because I put it in.
I didn't know what you were going to do.
So I decided that what I'll do is what it is not, and it's important. All memory problems are not Alzheimer's disease, and when you make Alzheimer's disease, you need to make a affirmative diagnosis, not by just going to someone and they think that you're Alzheimer's disease. It's a complex enough thing that 10% of the people who are diagnosed with this disease don't have it, probably. I'll take a couple of questions, and thank you for correcting me about palliative care in hospitals. Yes, ma'am.
How useful is doing an MMSC?
Well, MMSC is just little Goldman. It's a mini Goldman, MMSC, and there's there are a whole bunch of little things which, I'm lazy because I've got Goldman, so. But MMSC is a good tool, but you should do, or you can do good mental status exam yourself. You can do memory, abstraction, calculations, memory, have the draw clock and all that kind of stuff. The MMS is good because it's being spoon-fed to clinicians, so they just have forms. I don't like forms anything. But, any other questions or comments?
Can you say something about something like that, neurocognitive deficits, and then on the report I had, it had that diagnosis and then dementia parentheses behind it.
Ask him. He is the culprit behind that. And he's going to talk about it. He's going to ask him. Because, we talk about it. Now you have created a monster. You better take care of it. Yeah, he'll talk about it. Yes, ma'am.
Well, for speakers.
Oh, the medications for Alzheimer's? There are cholinesterase inhibitors, which are donepezil, Aricept, and Exelon. Aricept is by mouth, Exelon is a patch, and that improves memory. The Aricept and Exelon, and I won't go into generics and all that kind of stuff. The other medication is called Namenda, and it's an NMDA antagonist, and that's the only medication that has been shown to slow down the progression of the disease. And Namenda is made by Forest Pharmaceutical Company. Their patent ran out. It should be 10 milligrams twice a day. The patent ran out, so they made it an extended release Namenda now, so they can charge you $400 a month, and they're trying to suppress the generic production of Namenda. And Exelon is the patch is much better than PO drugs, oral drugs like Aricept, Razodine, because you have less nausea, less vomiting, and it's much easily tolerated. Having said all these medications, these are not spectacularly effective medicines. I don't know, we don't have any boots by pharmaceutical companies, so I can say that loudly. They're okay. They're like, there's a Far Side cartoon where husband and wife, and the wife says to husband, I'm sick and tired of everybody calling you Alexander the Pretty Good. So these are Alexander the Pretty Good medicines. They're not Alexander the Great. So, thanks, guys.
Go so quickly, my love. How did we get to be gray? Decades go by in the blink of an eye. It still feels like just yesterday. The first time that I heard you say, love me forever and hold me right now. Gather our memories like this. I know we'll never be old anyhow. Anytime we reminisce, I'll be as young as you're